Welcome to The Explainer. Today, we're putting ourselves right on the front lines of the postpartum ward, looking squarely at one of the highest stakes clinical scenarios you are ever going to face, bacterial sepsis following pregnancy. We're using the Royal College of Obstetricians and Gynecologists Green Top Guideline 64B as our ultimate playbook. Picture this. It's the middle of a crazy busy shift, a postpartum patient suddenly deteriorates, and the clock is instantly ticking. Your clinical reflexes in those next few minutes will literally mean the difference between life and death. So, let's get focused and action-oriented.
20 to 40%. Let that sink in for a second. That is the mortality rate for severe postpartum sepsis. I want to hit you with this stark reality right up front to establish the absolute clinical gravity of what we're dealing with here. This isn't a scenario where we can afford to just wait and see. Sepsis in a postpartum woman is a rapid, ruthless disease. The need for rapid, decisive intervention is paramount, mostly because delayed recognition is one of the primary drivers of maternal death.
Okay, let's dive into this. Consider this agenda your mental filing cabinet for the ward today. 1. Defining postpartum sepsis. 2. The Group A strep threat. 3. Recognizing clinical red flags. 4. Executing the sepsis 6. And 5. Source control and antibiotics. All right, starting off with Section 1, Defining Postpartum Sepsis.
So here's our working definition of puerperal sepsis. Notice the time frame clearly, it's super important. This risk window stays wide open from the very onset of labor or rupture of membranes all the way up to 42 days postpartum. Now, when we're hunting for the source of this infection, the guideline tells us that endometritis is the most common culprit. But, you know as well as I do, you've got to maintain a high index of suspicion. You have to actively hunt for other sources, like infected C-section or perineal wounds, UTIs, and mastitis. You really have to investigate the whole patient.
And, well, this is the terrifying progression we're trying so hard to prevent: septic shock. This is defined by persistent tissue hypoperfusion and hypotension that simply won't respond, even after you've provided adequate fluid resuscitation. At this stage, you're looking at a mortality rate that rockets up to 60%. 60%! This vividly highlights why we are in a literal race against the clock. Once organ dysfunction sets in, the window for saving your patient's life narrows drastically.
Moving right into Section 2, the Group A strep threat.
Now, what's really interesting here is the incredibly deceptive clinical contrast with this specific pathogen. Early symptoms like fever, malaise, myalgia, they just seem like a subtle flu-like illness, right? But contrast that early presentation with a rapid onset of toxic shock syndrome, multi-organ failure, and disseminated intravascular coagulation. Group A strep produces exotoxins that trigger a massive, overwhelming systemic response. A patient can go from feeling a little achy and tired to catastrophic multi-organ failure in hours. You absolutely cannot let those early, subtle signs lull you into a false sense of security.
Listen, if you take only one clinical pearl away from this entire explainer, let it be this exact phrase: severe pain out of proportion to examination findings. The confidential inquiry reports highlight this over and over again. If your patient is complaining of constant severe abdominal or pelvic pain that isn't touched by standard analgesics, and it seems way worse than what you're finding on physical exam, that is a massive, glaring red flag. It points directly toward Group A strep or a necrotizing infection, and it demands your immediate aggressive attention.
Which brings us to Section 3, recognizing clinical red flags.
I really want you to mentally hardwire these numbers into your brain. A systolic blood pressure dropping below 90, oxygen saturations dipping under 95%, a respiratory rate climbing over 20 to 30 breaths a minute, a heart rate racing past 130, or maybe reduced urine output, or a patient who suddenly becomes confused, agitated, or has a reduced level of consciousness. Any of these mean severe sepsis until proven otherwise. And please listen closely. You must never, ever assume that the absence of a fever means the absence of sepsis. Patients can be completely afebrile and still be in profound, life-threatening septic shock.
Okay, Section 4, Executing the Sepsis 6.
But before we actually list the steps, I need to emphasize this absolute golden rule from the guideline. Do not delay antibiotics while awaiting cultures. Look, while taking blood, high vaginal, and wound swabs is absolutely vital, delaying broad-spectrum IV antibiotics just because you're waiting on a culture is a major preventable cause of maternal death. Don't do it.
So to execute this flawlessly under high-stress ward conditions, we break this down using the highly memorable 3 to give, 3 to take chunking method. First up, the 3 to give. Give high-flow oxygen, give broad-spectrum IV antibiotics, and give rapid IV fluid crystalloids. Then we have the 3 to take. Take blood cultures, take a serum lactate measurement to check for tissue hyperperfusion, and take accurate urine output measurements, which, let's be honest, often means inserting a catheter. 3 to give, 3 to take. And all of this needs to happen within 1 single hour.
Finally, let's hit Section 5, Source Control and Antibiotics. So, this table maps out our targeted empirical therapy. For suspected endometriitis, common regimens lean toward comoxiclav or a clindamycin and gentamicin combo depending on your local policy. But look at the bottom row. This brilliantly illustrates the specific pharmacology of managing Group A strep. If GAS is suspected, the recommended regimen is high-dose penicillin plus clindamycin. Now, why the clindamycin? Because clindamycin actively suppresses the production of those lethal exotoxins that cause toxic shock syndrome. It's a highly targeted, literally life-saving addition. But here's a critical clinical dilemma for you. You've recognized the red flags. You've executed the Sepsis 6 flawlessly. You've given the high-dose penicillin and clindamycin. But the patient is still deteriorating. What happens when antibiotics simply aren't enough?
While that question pivots us directly to the absolute necessity of surgical intervention, which we call source control. If you've got infected retained products of conception, they require surgical evacuation. If imaging reveals a pelvic abscess, it needs physical drainage. And if you're looking at an infected wound or you suspect necrotizing fasciitis, that demands urgent surgical debridement. So the crucial point is this. Intravenous antibiotics alone will often completely fail if the physical source of the infection is still sitting inside the patient. Source control is just as important as the antibiotics, period.
All right, we've covered the definitions, the terrifying speed of Group A strep, the red flags, the Sepsis 6, and the absolute need for source control. The Rcog TG64B gives us the perfect framework. But frameworks only work if clinicians actually act on them. Delayed recognition and delayed escalation are the major drivers of maternal mortality. So, I'm going to leave you with this provocative thought to take with you on your very next shift. When that subtle flu-like symptom presents or that pain out of proportion hits, are your clinical reflexes sharp enough to beat the golden hour? Keep this knowledge close, stay vigilant, and I'll catch you on the next explainer.